Welcome to The Deep Dive, the show where we cut through the noise, unpack complex medical topics, and pull out the crucial insights that can genuinely elevate your clinical practice. Today, we're plunging into a subject that, well, at first glance seems incredibly straightforward, yet it consistently throws up significant challenges in diagnosis, treatment, and especially long-term patient recovery: ankle sprains. Now, when we talk about how common these are, the figures are really quite startling. We're looking at an estimated 28,000 ankle sprains happening every single day in the United States alone.
28,000 a day, that's huge.
It really is. And if you've spent any time in sports medicine or even A&E, you'll know it's often the single biggest reason why athletes miss participation. So, despite their ubiquity, their impact, both on individuals and on healthcare systems, is undeniably profound. Our mission today is to unpack the intricate nuances of these injuries, from the fundamental anatomy that underpins them to the cutting-edge advanced treatment protocols and, crucially, the prevention strategies that can make all the difference. We want to provide you, our discerning medical professional listener, with a comprehensive yet concise understanding that you can apply directly. And to guide us through this intricate landscape, I'm absolutely thrilled to welcome Prof. Mo Imam.
Thank you so much for having me. It's a genuine pleasure. You've really nailed the core issue right there. Ankle sprains are indeed incredibly common, almost a rite of passage for many active individuals, aren't they?
Almost seems that way sometimes.
But the critical point, and one that's so often underestimated, is their potential for serious, debilitating long-term complications if they're not managed appropriately from day one. We frequently see patients in clinic years down the line, still grappling with persistent pain, instability, or even early arthritis, all stemming from an initial sprain that simply wasn't given the attention it deserved.
So that initial management is key.
Absolutely critical. For this deep dive, we're going to embark on a comprehensive journey, starting with the very first moment of injury, understanding the mechanisms, then moving through precise diagnostic approaches, exploring the full spectrum of treatment from conservative to operative, and finally, really honing in on robust prevention strategies. Our shared aim is to arm you with actionable, evidence-based insights that can significantly improve patient outcomes.
Right then, let's roll up our sleeves and get into it. Before we even begin to unpick the various types of ankle injuries and their manifestations, could you perhaps take us back to basics? For many of us, it's been a while since anatomy lab. Could you refresh our memory on the critical structural foundations of the ankle? Specifically, which ligaments are the prime suspects, the most vulnerable players, in a typical ankle sprain scenario?
Absolutely. Happy to. It's always vital to start with the foundations, as understanding the anatomy illuminates the pathology.
Yeah.
The ankle joint itself it's a marvel of engineering, really.
Yeah.
A complex articulation involving three primary bones: the tibia and fibula, which are the long bones of your lower leg,
Right.
and the talus, the crucial bone in your foot, that essentially acts as the fulcrum between your leg and the rest of your foot.
The connecting piece.
Precisely. These three bones are held together, quite ingeniously, by a sophisticated network of robust ligaments. These aren't just passive restraints. They provide both the necessary static stability and also guide the intricate range of motion required for everything from a gentle stroll to a full-on sprint. When we talk about ankle sprains, we're almost exclusively referring to injuries to these ligaments, and we can broadly categorize them into two main groups, based on their location and the type of force they resist. On the outer side of the ankle, the lateral aspect, we find the ligaments that are, unfortunately, the most frequent victims in ankle sprains. The absolute lead character here, if you will, the one that gets injured most commonly, is the anterior talofibular ligament, or ATFL.
ATFL, okay.
This ligament is quite slender and is positioned anteriorly at the front, connecting the fibula to the talus. It's typically injured when the foot is in a plantar flexed or pointed down position and then rolls inwards, that classic inversion mechanism, like stepping awkwardly off a curb or landing badly from a jump.
The classic going over on your ankle.
Exactly that. It's the weakest of the lateral ligaments, which is why it bears the brunt of most inversion injuries. Following the ATFL in terms of injury frequency is the calcaneofibular ligament, or CFL. This one sits a bit deeper and more vertically, connecting the fibula to the calcaneus, your heel bone.
So fibula to heel bone.
Correct. It tends to be affected when the foot is in a more neutral or even dorsiflexed upwards position during an inversion injury. A critical distinction with the CFL is its role not just in ankle joint stability, but also in supporting the subtalar joint, which allows for inversion and eversion of the foot.
So it affects more than just the main ankle hinge.
Indeed. An injury to the CFL can have broader implications for foot mechanics. And then less commonly involved, usually only in quite severe or multiligamentous injuries, is the posterior talofibular ligament, or PTFL, which, as its name suggests, is at the back. Now, shifting our focus to the inner side of the ankle, the medial aspect, we encounter the exceptionally strong deltoid ligament.
The medial side, right.
Yes, this isn't a single band, but rather a broad, fan-shaped complex made up of several distinct parts. It provides truly substantial support to the inner ankle and plays a crucial role in limiting talar abduction. That's the outward movement of the talus.
Okay.
And its deep portion is particularly good at limiting external rotation of the talus. Essentially, it's the primary guardian against excessive eversion of the foot, where the ankle rolls outwards.
So it stops the ankle collapsing inwards effectively.
Precisely. It resists that outward roll, the eversion. Interestingly, because of its inherent strength and broad attachment, isolated injuries to the deltoid ligament are relatively rare.
You don't see them often on their own.
Not usually. When they do occur, they often signify a higher energy trauma or occur in conjunction with other injuries, sometimes even a fracture, because the bone gives way before the ligament does.
Right, the forces must be significant.
They usually are. So understanding these specific anatomical relationships, knowing exactly which ligament sits where and how it functions to provide stability, is absolutely paramount. It's what allows us to accurately diagnose the mechanism of injury when a patient walks into our clinic.
That's a truly excellent anatomical breakdown, Prof. It really paints a clear picture and sets the stage for understanding the injury itself. So with that intricate anatomy now firmly in our minds, let's move on to the practical reality. What are the primary types of ankle sprains we commonly encounter in clinical practice, and how do their underlying mechanisms and defining characteristics truly differ? I mean, it's not just a twisted ankle, is it?
Precisely. It's far more nuanced than just a twisted ankle. For clinicians, classifying these injuries is fundamental to effective management. We primarily categorize ankle sprains based on the direction the foot moves during the injury, which in turn dictates which ligaments bear the brunt of the force. There are essentially three main types we encounter. First, and by far the most ubiquitous, are inversion sprains. These are what many colloquially refer to as low ankle sprains, and they represent over 90% of all ankle sprains we see.
Over 90%?
Easily. The mechanism is exactly as it sounds. The foot rolls inward, often quite violently, leading to damage of those lateral ligaments we just discussed, predominantly the ATFL and frequently the CFL as well, especially if the injury is more severe.
So the outer ligaments.
Yes. The classic scenario is an inversion injury on a plantar flexed foot. Think of stepping into a pothole, landing awkwardly after a jump in netball, or simply misjudging a step off a curb. The forces here can be quite significant, often leading to immediate pain and swelling on the outer side of the ankle. Secondly, we have eversion sprains. These are significantly less common, and for good reason. As we just highlighted, the deltoid ligament on the inner side of the ankle is exceptionally robust.
A big fan-shaped one.
Exactly. An eversion sprain occurs when the ankle rolls outward, placing immense stress on this formidable deltoid ligament. These types of sprains typically demand a much more forceful external rotation or abduction mechanism, often involving a higher energy impact, such as a contact sports injury or a motor vehicle accident. Because the deltoid is so strong, an isolated eversion sprain is rare. You're often looking for an associated fracture, perhaps of the fibula, because the bone might break before the ligament pairs.
Interesting.
And thirdly, a less common, but often far more debilitating and challenging type are syndesmotic sprains, universally known as high ankle sprains.
The dreaded high ankle sprain.
Indeed. While they only account for about 1% to 10% of all ankle sprains, their significance is disproportionately high. These injuries involve the tibiofibular ligaments, specifically the anterior and posterior tibiofibular ligaments, and the interosseous membrane, which connect the tibia and fibula bones above the actual ankle joint.
Right, higher up the leg.
Correct. They're critical for maintaining the integrity of the tibiofibular syndesmosis, which forms the roof of the ankle mortise. These sprains are frequently associated with high-impact activities and powerful twisting motions, particularly where there's external rotation of the foot on a fixed or planted leg or hyperdorsiflexion.
Like in rugby or football tackles.
Exactly those sorts of scenarios. Think of a rugby player getting tackled with their foot caught or a footballer twisting on the pitch. The key takeaway here is that syndesmotic injuries can lead to significant and chronic instability if not correctly identified and managed, and they invariably demand a much, much longer recovery period compared to the more common lateral sprains.
Much longer recovery, okay.
Significantly longer.
Yeah.
Beyond the specific mechanism, we then classify ankle sprains by their severity, which naturally directly dictates the immediate management plan and the prognostic outlook. This uses a widely accepted three-grade system, and it's essential for clinical decision-making. Grade I sprains represent the mildest form. Here, there's just a slight stretching of the ligament fibers, perhaps with some microscopic tears. Clinically, you'll observe minimal pain, often a bit of mild swelling, and perhaps very slight, localized ecchymosis or bruising.
So quite subtle sometimes.
Can be. Crucially, the patient can usually bear weight normally, albeit perhaps with some discomfort, and there's no detectable ligamentous instability during your physical examination. They might feel a bit stiff, but the joint itself feels solid. Grade 2 sprains indicate a more significant injury, a partial tearing of the ligament. At this grade, the pain is moderate, and you'll typically see more noticeable swelling and bruising. Patients will experience mild to moderate pain with weight bearing, and during your examination, you might detect slight but definite instability.
A bit wobbly.
A bit wobbly, yes. A classic, though not universal, presentation for grade 2 sprains is often a characteristic horseshoe-shaped bruise that appears around the heel.
Ah, yes, I've seen that. Sort of wraps around the malleolus.
Exactly. That pattern is quite indicative of the extent of the soft tissue damage and the underlying hematoma. Finally, grade 3 sprains represent the most severe injury, a complete rupture of one or more ligaments. These are truly painful injuries, presenting with pronounced, often excruciating, pain, significant and rapid swelling, extensive ecchymosis that can spread quite widely, and sometimes even a visible deformity of the ankle due to the swelling and instability.
Can't bear weight at all, usually.
Often impossible or severely painful. And during your examination, you will detect substantial instability of the joint. It's this grade in particular where meticulous and careful management is absolutely critical to prevent the transition to long-term chronic instability and other complications we'll discuss later.
Makes sense.
Understanding these grades is truly fundamental for any clinician, as it directly guides your immediate therapeutic approach and helps in setting realistic expectations for the patient's recovery trajectory.
That distinction between the specific mechanisms and then the subsequent severity grading is incredibly helpful for navigating what patients present with. It transforms a vague, twisted ankle into a precise diagnosis. Now let's pivot and consider the why behind these injuries. What are the typical scenarios that often lead to ankle sprains, and what should we as clinicians be acutely aware of regarding both intrinsic, patient-related factors and extrinsic environmental risk factors? What makes someone more vulnerable?
It's a fantastic question, because understanding the etiology is paramount, not just for acute management, but crucially for prevention. The primary cause of an ankle sprain is almost always a sudden, uncontrolled, and forceful twisting motion of the foot or ankle.
Right.
This can manifest in a myriad of common scenarios. Think of simply misstepping on uneven terrain, that unexpected dip in a pavement, or a rogue tree root on a trail run. Tripping or falling is another ubiquitous cause, where the foot can unexpectedly roll inward or outward upon impact, or as you lose balance.
Happens to everyone.
It really does. However, a very significant proportion of ankle sprains, especially the more severe ones, occur during sports and high-impact activities. Any sport that demands sudden directional changes, rapid pivoting, quick cuts, or repetitive jumping is inherently high risk. We're talking about basketball, volleyball, tennis, football, rugby, netball, essentially any dynamic sport where the foot can get caught or twisted while the body continues its motion.
Landing awkwardly from a jump, perhaps?
Very common mechanism.
Yeah.
In the more severe cases of ligament tearing, patients will often vividly report hearing or feeling a distinct pop or snap at the very moment of injury.
Ah, the pop. Always makes your ears prick up.
It certainly should. This auditory sensory feedback is a strong indicator of a significant ligamentous event, often a complete rupture, and should immediately raise your index of suspicion during history taking. Beyond these direct causes, we also identify a number of key risk factors that predispose individuals to ankle sprains or to recurrent sprains. These are broadly categorized into patient-related or intrinsic factors and environmental-related or extrinsic factors.
Okay, intrinsic first.
Yes. On the intrinsic side, we frequently observe individuals with pre-existing biomechanical limitations. For example, limited dorsiflexion. That's a restricted upward movement of the foot towards the shin.
Stiffness going upwards.
Exactly. That significantly increases risk because it limits the anchor's ability to absorb shock and adapt to uneven surfaces. Similarly, decreased proprioception. The body's subconscious awareness of its position in space and a general balance deficiency are major contributors.
So poor balance control.
Precisely. If your body isn't getting accurate feedback on where your foot is in relation to the ground, or if your reflexive muscle responses are slow, you're far more likely to roll your ankle. Furthermore, a subtle cavivarious foot alignment, a foot structure characterized by a high arch and a heel that turns slightly inward.
High arches, heel turned in.
Yes, that can place the ankle in a persistently more vulnerable position for recurrent inversion injuries. This is a structural predisposition that puts the lateral ligaments under greater baseline tension,
Making them more prone to injury.
inherently more prone. As for the extrinsic factors, indoor court sports have historically presented the highest risk, primarily due to the combination of rapid, multi-directional movements on often hard, unforgiving surfaces that offer high friction, sometimes causing the foot to stick while the body rotates.
Like basketball or netball court.
Exactly. Recognizing these modifiable risk factors is absolutely paramount. It's not just about treating the acute injury, it's about implementing effective long-term prevention strategies, particularly within athletic populations, to break that cycle of recurrent sprains.
It's fascinating how those subtle biomechanical and environmental factors can contribute to such a common injury. Now, when a patient actually walks into our clinic with a suspected ankle sprain, often in quite a bit of pain and distress, what are the absolute key symptoms we should be looking out for? And crucially, what are the essential elements of our clinical and imaging evaluations to ensure we arrive at an accurate diagnosis and, perhaps even more importantly, rule out anything more sinister, like a fracture or a more complex injury?
This is truly where our clinical judgment shines, isn't it? When a patient presents, the symptoms they report will naturally guide your initial assessment. The most prevalent symptoms include acute pain, which can range from a dull ache to a sharp, incapacitating pain, present at rest, exacerbated with weight bearing, or during any movement of the ankle.
Pain is obviously number one.
Almost always. You'll almost invariably observe varying degrees of swelling and ecchymosis or bruising around the affected area. This can be anything from mild puffiness to extensive disfiguring bruising that spreads widely across the foot and ankle. A very strong diagnostic indicator is tenderness to touch, specifically localized over the involved ligaments. This pinpoint tenderness directly over the ATFL or CFL, for example, is highly suggestive of their involvement.
Finding that exact spot.
Yes, it's very helpful. Patients will often describe a feeling of ankle instability or a sensation of the ankle giving way, particularly during movement or weight-bearing activities, even if it's a subtle feeling. Restricted range of motion is also extremely common due to pain, swelling, and muscle guarding.
They just don't want to move it.
Understandably. Less commonly, but important to note, some individuals might report numbness or tingling sensations in the foot or ankle, which warrants consideration of nerve involvement. Red flag there. Potentially, yes. Needs careful assessment. And for those with recurrent sprains, they might describe new or persistent catching or popping sensations, which can signal associated intra-articular pathology, perhaps a loose body or cartilage damage. Now, moving on to the clinical evaluation itself. It begins, as always, with a meticulous history. Understanding the precise mechanism of injury is crucial. How exactly the foot twisted, the direction of force, the surface, any immediate sounds or sensations like that pop we discussed.
Getting the story straight.
Absolutely. This immediately helps you narrow down which ligaments might be affected and the potential severity. The physical examination, while potentially painful for the patient due to acute inflammation and swelling, is absolutely essential. First, observation. Visually assess the injured ankle. Crucially, compare it to the contralateral uninjured ankle.
Always compare.
Always. Look for the extent of swelling, the exact location and pattern of ecchymosis. Is it the classic horseshoe bruise? Is it more diffuse? Then, palpation. Gently but systematically palpate around the entire ankle, pinpointing tenderness directly over specific injured ligaments like the ATFL just anterior to the lateral malleolus or the CFL inferior to it is a key diagnostic step. You're also palpating around the malleoli and the base of the fifth metatarsal and navicular bone to rule out bony tenderness.
Checking those Ottawa rules points.
Exactly. We'll come back to those. Next, range of motion testing. Gently assess both active and passive movement of the ankle in all planes. While this will often be limited by pain and swelling in the acute phase, it gives you a baseline for functional impairment. Next, range of motion testing. Finally, and critically, stability testing helps assess the integrity of the ligaments. The anterior drawer test is performed to check for excessive anterior displacement of the talus relative to the tibia. It's often best tested with the foot in slight plantar flexion when assessing the ATFL and in dorsiflexion for the CFL.
Testing that forward glide.
Correct. However, its usefulness can be somewhat limited in the acute setting due to patient pain and muscle guarding. The talar tilt test evaluates excessive ankle inversion typically. A difference greater than 15 degrees compared to the uninjured side is considered significant.
15 degrees difference.
Yes, that's the threshold often cited. It strongly indicates injury to both the ATFL and CFL. This test is particularly valuable for diagnosing CFL injury by directly assessing overall ankle instability in the coronal plane. Now, regarding imaging studies, radiographs or X-rays are almost always your first-line imaging modality. Their primary purpose is to rule out fractures, which can often present with symptoms very similar to severe sprains.
Crucial first step.
Absolutely. The indications for X-rays are brilliantly guided by the widely adopted Ottawa ankle rules. These rules are incredibly sensitive, boasting a sensitivity between 96% and 99% for ruling out clinically significant ankle fractures.
Very sensitive indeed.
Meaning, if the patient doesn't meet the criteria, you can generally confidently exclude a fracture without X-rays, thereby reducing unnecessary radiation exposure. You should order X-rays if the patient presents with an inability to bear weight both immediately after the injury and in the emergency department or clinic, or if there's point tenderness over the posterior edge or tip of either the medial or lateral malleolus, or tenderness at the base of the fifth metatarsal or the navicular bone.
So weight-bearing ability and those specific bony points.
Those are the key criteria. Standard views include AP, lateral, and mortise views, with weight-bearing views where possible to assess joint space integrity under load. For suspected high ankle sprains, stress X-rays can be particularly useful for diagnosing syndesmosis injury.
Stress views for the high sprains.
Yes. You're specifically looking for asymmetric widening of the mortise, specifically a medial clear space widening greater than 4 millimeters, and a tibiofibular clear space widening of 6 millimeters or more. These measurements indicate a diastasis, or separation, of the tibia and fibula. Varus stress views can also be used to diagnose CFL injury by assessing for an increased talar tilt. MRI is generally not routinely needed for the initial diagnosis of a straightforward ankle sprain. However, you should definitely consider an MRI if pain and instability persist for 6 to 8 weeks following the initial sprain, despite appropriate conservative management.
If things aren't getting better.
Exactly. Or if you strongly suspect associated injuries that plain X-rays can't visualize. It's an excellent modality for evaluating soft tissue structures like peroneal tendon pathology problems with the tendons on the outer ankle, osteochondral lesions of the talus, which are areas of damaged cartilage and underlying bone, occult or hidden syndesmotic injuries that weren't clear on X-ray, anterior or anterolateral synovitis, which is inflammation of the joint lining, or anterior ankle impingement, where soft tissues get pinched in the front of the ankle.
So MRI for the complications or persistent symptoms.
That's the general rule. Lastly, quick word on referral considerations. Orthopedic referrals are warranted for specific situations. This includes any suspected fractures that aren't clearly benign or simple on X-ray, any signs of neurovascular compromise, numbness, tingling, diminished pulses.
Urgent referral for those.
Absolutely. Suspected tendon ruptures, such as the Achilles or peroneal tendons. Symptoms that are disproportionate to the trauma observed, perhaps indicating a more complex underlying issue, or if there's persistent diagnostic uncertainty after your initial thorough clinical and imaging workup. These are the cases that truly demand specialist input to ensure optimal outcomes.
That's a truly comprehensive and incredibly practical roadmap for diagnosis, Profess. It really demystifies the initial clinical encounter. So once we've accurately diagnosed an ankle sprain, and we've got a clear picture of its type and severity, the next critical hurdle is effective management. How do we best approach treatment from those initial conservative measures that apply to the vast majority of patients to considering surgical intervention for those specific, often more complex circumstances? I imagine it's a careful balance, particularly with athletes keen to return to play.
It is indeed a careful balance, and a multi-phased approach is key. For the overwhelming majority of low ankle sprains, including many severe grade 3 ligament tears, robust and effective healing can absolutely be achieved without the need for surgery, provided they are appropriately immobilized initially and, crucially, diligently rehabilitated.
So non-operative first for most.
The vast majority. Non-operative treatment typically begins with initial management, or Phase 1. This is where the well-known RICE protocol has historically held sway. Rest. Advise patients to avoid weight-bearing on the injured ankle or resuming sports activities that aggravate it. For more severe sprains, particularly grade 2 or 3, crutches may be recommended for a period to avoid weight-bearing completely and allow initial healing. Ice. Immediate application helps significantly to reduce swelling and pain. Recommend applying an ice pack for 20 to 30 minutes, 3 to 4 times daily, ensuring it's wrapped in a cloth to prevent direct skin contact and potential ice burns. Compression. Using elastic bandages, an ACE wrap, or compression stocking can help to both immobilize and support the ankle, while also actively managing edema. Elevation. Instruct patients to raise their ankle above heart level as often as possible during the first 48 hours. This uses gravity to help drain excess fluid and control swelling.
Right, see, everyone knows it.
Everyone knows it. Now, here's a critical insight that's shifting clinical practice. While rice has been a cornerstone for decades, recent evidence suggests its isolated effectiveness, particularly the R for rest and the I for ice, is somewhat limited in terms of accelerating definitive healing beyond immediate pain and swelling control.
Oh, interesting. So rice alone isn't the whole story.
Not entirely. Strong evidence primarily supports cryotherapy, or ICE, when combined with early controlled exercise therapy for truly improving functional outcomes. So it's not simply rest and ice, it's ice and move it judiciously.
Vice and movement.
Controlled movement, yes.
Yeah.
It's also important to advise patients to avoid harm in the first 2 to 3 days. Heat, alcohol, running, or excessive activity and massage, as these can exacerbate swelling and bleeding in the acute phase.
Avoid harm, remember rice, with caveats.
Exactly. Regarding immobilization, a short period of immobilization, perhaps around 1 week, in a walking boot, an air cast, or a walking cast, may be required, particularly for grade 2 sprains, or those with significant pain. For grade 3 sprains, a slightly longer period of casting or bracing for 10 to 14 days with strict non-weight bearing might be beneficial to protect the completely torn ligament in its initial healing phase.
So immobilize, but not for too long.
That's the key. The overarching principle that has emerged strongly in the last decade is that early mobilization generally facilitates a better and quicker recovery, leading to superior functional outcomes and less stiffness in the long run. So the immobilization period should always be as brief as clinically necessary, guided by the patient's pain levels and the stability of the injury. For medication, nonsteroidal anti-inflammatory drugs, or NSAIDs, such as ibuprofen, naproxen, or celecoxib, are widely used for pain relief and swelling reduction. They are generally preferred over narcotic painkillers for mild to moderate sprains, as they improve function by addressing both pain and inflammation.
Standard NSAIDs.
Yes. However, and here's another nuanced insight for our listeners, it's worth noting the potential for NSAIDs to actually delay the natural healing process in some contexts. This is because they suppress the inflammatory response, which, ironically, is a necessary and initial component of the body's natural tissue repair process.
Right. Inflammation is part of healing.
It is. So while they provide symptomatic relief, we need to be mindful of this potential trade-off, especially in the very early stages of healing for more severe sprains. The true cornerstone of long-term recovery, particularly from phase 2 onwards, is dedicated physical therapy and rehabilitation. This is absolutely crucial irrespective of the initial severity.
Physio is key.
Absolutely. The early phase, phase 2, or functional rehabilitation, begins once the initial acute swelling and pain have subsided, usually within a few days to a week. This involves gentle motion exercises, progressing quickly to isometric strengthening, proprioception training, and activity-specific exercises. It's vital that any rigid immobilization is discontinued at this stage to prevent joint stiffness and muscle atrophy. The goal here is to regain a pain-free range of motion. The strengthening phase, phase 3, commences once full range of motion is achieved and pain is well under control. The primary focus here is on strengthening the peroneal muscles, that's the muscles on the outside of your lower leg, which are key dynamic stabilizers of the ankle and actively resist inversion.
Strengthening those outer muscles.
Crucial. Neuromuscular training, which helps improve the brain's communication with the muscles, is integrated. Gradual incorporation of resistance exercises, using bands, weights, or body weight, is key. Water-based exercises like aqua jogging or exercises in a pool can be incredibly useful for patients who are still experiencing pain during land-based weight-bearing exercises, as the buoyancy reduces load.
Hydrotherapy can be great.
Very helpful. Proprioception balance training is an absolutely essential component, particularly given that poor balance is a significant, well-established risk factor for recurrent sprains and chronic instability. These exercises are designed to enhance the body's awareness of joint position and movement. Think of simple exercises like standing on the affected foot with eyes open, then progressing to eyes closed.
Wobble boards and things like that.
Exactly. Or using unstable surfaces like a wobble board or foam pad. These drills are not just about balance. They help to re-educate the nervous system, training faster, more reactive responses from the peroneal muscles during dynamic activities, helping the ankle to catch itself before it rolls. Endurance and agility exercises are gradually introduced once the patient is pain-free and has achieved good strength and balance. Examples include progressively smaller figure-of-8 running drills, side-to-side shuffles, or ladder drills. These improve agility, ankle strength, and calf endurance, simulating sport-specific movements. A functional brace that specifically controls inversion and eversion is typically recommended for use during the strengthening period, and often as a prophylactic measure for high-risk activities, particularly in the early return-to-sport phase.
Bracing for sport.
Often advisable, especially initially. In terms of outcomes for non-operative treatment, consistent evidence shows that early functional rehabilitation consistently leads to the quickest return to physical activity and superior long-term outcomes. While supervised physical therapy shows early benefits in terms of patient confidence and adherence, there isn't convincing evidence of a significant long-term difference in outcome compared to a well-structured, unsupervised home program for mild to moderate sprains, provided the patient is compliant.
So home exercises can work well if done properly.
They certainly can. Also, it's an important point for clinicians that there's no convincing evidence that the future development of chronic ankle instability can be reliably predicted solely by history, acute physical examination, or initial radiographic parameters. So a seemingly minor sprain can still lead to long-term issues if not rehabilitated properly.
You can't always tell at the start.
Not reliably, no. Return to play or activity varies significantly and must be individualized. It depends heavily on the sprain's grade, whether there's syndesmosis involvement, as high ankle sprains take longer, any associated injuries, and critically, the patient's compliance and progression through the rehabilitation program. As a general guideline, Grade 1 sprains typically allow return within 1 to 2 weeks. Grade 2 sprains usually take 2 to 4 weeks. Grade 3 sprains generally require 4 to 8 weeks.
And high ankle sprains.
They take longer. For high ankle sprains managed with immobilization, recovery can be 6–12 weeks. If screw fixation is required for a high ankle sprain to stabilize the syndesmosis, it can even be a season-ending injury for an athlete, requiring 4 to 6 months before return to sport. Overall, recovery can range from as little as 2 weeks for very minor sprains to 3–6 months for more severe, complex injuries.
Quite a range.
A very wide range. Now, for operative treatment, it is thankfully rarely required for the majority of ankle sprains. Surgery is typically considered only for specific, well-defined circumstances.
When does surgery come into play?
The primary indications for surgery include persistent pain and chronic ankle instability. Despite an extensive and rigorous course of non-operative management, and we're talking about months of dedicated supervised rehabilitation, not just a few weeks.
After failed conservative treatment.
Yes, genuine failure despite best efforts. It might also be considered for grade 3 sprains if there's a significant bony avulsion, meaning a piece of bone has been pulled off by the ligament. Certain high ankle sprains with clear tibiofibular diastasis, which is that pathological widening or separation between the tibia and fibula, often indicating a complete syndesmotic disruption, are also surgical candidates.
Unstable high ankle sprain.
Correct. Furthermore, if there are associated significant injuries identified, such as osteochondral lesions, cartilage damage on the talus, ruptured peroneal or other tendons, or significant impingement syndromes that don't respond to conservative care, then surgery may be necessary to address these concomitant issues. As for the types of surgery, arthroscopy is a minimally invasive keyhole procedure, often performed prior to open ligament reconstruction. It allows the surgeon to inspect the entire joint meticulously, identify and debride any impinging scar tissue or synovitis, or remove loose fragments of bone or cartilage that might be causing ongoing pain, catching, or mechanical symptoms.
We look inside first.
Often very helpful, yes. It's an excellent diagnostic tool as well as therapeutic. For the ligament repair or reconstruction itself, there are two main approaches. The gold standard for chronic lateral ankle instability is the anatomic reconstruction, famously exemplified by the Gould modification of the Brostrom procedure.
The Brostrom.
That's the one. This procedure involves shortening and reinserting the ATFL and CFL to their anatomical origins and insertions, often reinforced with the inferior extensor retinaculum and distal fibular periosteum, which are local soft tissues providing additional strength. In more recent years, suture tape augmentation, where a strong tape is placed alongside the repair, has been shown to further increase the strength and early stability of this repair, allowing for potentially faster rehabilitation.
Adding extra support.
Exactly. A critical point to remember with this procedure is that if the ligaments are overtly lightened, it can unfortunately lead to a restricted range of dorsiflexion postoperatively, causing stiffness. The outcomes for the Brostrom Gold are generally very good, with good to excellent results reported in about 90% of cases.
High success rate.
Generally, yes. Alternatively, particularly in cases of severe instability, failed previous repairs, or significant tissue laxity, there are tendon transfer or tenodesis procedures. Examples include the Watson-Jones, Christman-Snook, Colville, or Evans techniques. These are considered non-anatomic reconstructions because they don't recreate the original ligament anatomy directly. Instead, they use a segment of a healthy local tendon, often one of the peroneal tendons, which is then passed through bone tunnels to create a new functional restraint.
Using a tendon instead of repairing the ligament.
Correct. It's absolutely critical that any pre-existing foot or ankle malalignment, such as a hindfoot varus where the heel turns inward, is identified and corrected, often assessed with something like Coleman block testing, before these procedures are undertaken, as malalignment can jeopardize the success of the reconstruction.
Need to fix the alignment first.
Absolutely essential. A common complication with these non-anatomic reconstructions, due to their altered biomechanics, can be subtalar stiffness, which can affect foot mobility. Post-operative recovery following surgery invariably involves a period of immobilization in a cast or protective boot, typically for 4 to 6 weeks, to safeguard the delicate repaired ligaments during their initial healing. Strict adherence to non-weight-bearing protocols during this crucial initial phase is absolutely critical to prevent re-tear of the surgical repair.
Protecting the repair.
Vitally important. Rehabilitation then commences, focusing intently on regaining strength and range of motion, similar in principle to conservative rehab, but often more gradual initially. Recovery takes weeks to many months, depending on the extent of the original injury and the specific type of surgery performed. While some newer mobilization protocols advocate for earlier postoperative mobilization to improve functional scores, it's a careful balance, as they can also potentially lead to increased ankle laxity and a slightly higher risk of wound healing complications if not managed meticulously.
That distinction between non-operative and operative strategies and the intricate nuances within each is incredibly insightful, Professor. It highlights the depth of decision-making involved. But as the old saying goes, and it holds so true here, prevention is always better than cure. How can we as clinicians truly empower our patients, especially our athletes, like our hypothetical netball player, Sarah, who just wants to get back on court without constant fear, to proactively reduce their risk of both initial ankle sprains and, critically, those debilitating recurrent injuries?
This is indeed a vital area, and one where we can make a tremendous impact on a patient's long-term quality of life. It genuinely requires a multifaceted approach, empowering patients to be proactive in consistently maintaining their ankle strength, balance, and flexibility. For us as clinicians, the focus must be on targeting and modifying any identifiable intrinsic and extrinsic risk factors.
Tackling those risk factors we talked about.
Exactly. One of the most fundamental, yet often overlooked aspects is footwear selection. This is absolutely crucial for providing adequate support and stability. For individuals whose feet pronate excessively or who have naturally low arches, often referred to as flat feet, advise them to opt for shoes that offer robust arch and front foot support, coupled with a stable, firm heel counter.
Supporting the flat foot.
Yes, controlling that inward roll. Conversely, those with stiffer feet or high arches, a cavo-varus alignment, for example, may benefit more from cushioned and softer platforms, as their feet are inherently less shock absorbent. It goes without saying that sport-specific shoes are highly recommended. A runner needs running shoes designed for gait. A basketball or netball player needs court shoes with good lateral support and grip, and so on.
Right tool for the job.
Precisely. General cross-training shoes, while versatile, may not offer the precise support and stability needed for specific high-demand activities. And importantly, advise regular replacement of athletic shoes, typically every 6 months for regular runners, or even more frequently if the tread wears out or the shoe's cushioning and support degrade prematurely. A simple check is if the midsole feels flat or compressed.
Don't wear worn-out trainers.
A simple but effective message. Beyond footwear, exercise-based prevention truly forms the core of a robust program. Strengthening exercises are key to improving dynamic ankle stability. This includes simple calf raises, resistance band ankle exercises to target various planes of motion, dorsiflexion, plantar flexion, inversion, and eversion, and critically specific and dedicated strengthening of the evertor muscles, particularly the peroneals.
Again, those peroneal muscles.
They're the active stabilizers, resisting that inversion force. Proprioception exercises are absolutely essential. Given that poor balance and diminished joint awareness are such significant risk factors for recurrent sprains, exercises that enhance the conscious and subconscious awareness of joint position and movement are paramount. Think of single-leg balance exercises, progressively performed first with eyes open, then with eyes closed to remove visual cues, or using unstable surfaces like a wobble board, balance disc, or foam pad.
Training that balance reaction.
Exactly. These drills are profound. They help to re-educate the nervous system, training faster, more accurate neuromuscular responses from the peroneal and other stabilizing muscles during dynamic activities, helping the ankle to catch itself and correct its position milliseconds before a sprain occurs. A structured warm-up routine, including dynamic stretches and light cardiovascular activity targeting the lower limbs, should always precede any physical activity. This prepares the muscles and ligaments for the demands of the activity, increasing blood flow and elasticity, thereby reducing injury risk. And for those returning to sport or higher-level activities, incorporating progressive drills like quick support drills, shuttle runs, and dynamic landings can further enhance neuromuscular control, agility, and stability in sport-specific contexts. These drills mimic the demands of their sport, building confidence and resilience. Maintenance and activity modification are also critical for long-term success. Encourage patients to regularly include balance and strengthening exercises in their routine, perhaps 2 to 3 times per week, even when they feel completely well and pain-free.
Keep doing the exercises.
It isn't just rehabilitation, it's preventative maintenance. Furthermore, advise them to be mindful of and, whenever possible, avoid high-risk situations, stepping on uneven or slippery surfaces, especially when fatigued or distracted, significantly increases vulnerability to injury. Sometimes, just being aware of your environment can prevent an incident. Finally, when we consider return to activity for athletes like Sarah, it must be a meticulously gradual transition to sport-specific activities, ensuring full functional recovery, confidence, and assessed readiness before resuming previous intensity levels. For athletes with a history of prior sprains, a comprehensive prevention program is particularly important, and this may indeed include the consistent use of semi-rigid ankle orthoses or taping, especially for those who demonstrate a cavovarus foot alignment, to provide that essential additional mechanical support and proprioceptive feedback.
Bracing or taping for those at higher risk.
It can make a real difference. Implementing these measures consistently can dramatically reduce the risk of both initial ankle sprains and, crucially, that frustrating cycle of recurrence.
That's a truly powerful message on prevention, Prof, emphasizing that our role extends far beyond merely treating the acute injury. It's about empowering patients to stay robust. But even with the best care, diligent rehab, and robust prevention strategies, complications can, unfortunately, arise. What are the potential long-term complications of ankle sprains, and how do we, as clinicians, best identify and manage them to ensure optimal patient outcomes, avoiding that debilitating cycle of re-injury and chronic issues?
This is a critical discussion, because while the majority of ankle sprains do heal well with proper management, we absolutely cannot overlook the significant potential for long-term consequences if they are not correctly identified, managed, or rehabilitated. The most immediate and significant risk following an ankle sprain, especially if the ankle isn't adequately healed and strengthened before resuming full physical activity, is re-injury.
Going over on it again.
Exactly. The structural integrity of the ankle has been compromised, even if subtly, making it inherently more susceptible to future sprains. Each re-injury can progressively worsen the joint's stability. A notable and pervasive long-term consequence, affecting a significant proportion of patients, is chronic ankle instability, or CAI. This develops in an estimated 15% to 20% of patients, particularly when an initial ankle sprain, especially a severe one like a grade 2 or the third, isn't allowed to heal completely or isn't adequately rehabilitated.
15 to 20% is quite high.
It is worryingly high. CAI is clinically characterized by persistent pain, ongoing swelling that seems to come and go, and most tellingly, the ankle repeatedly giving way or feeling profoundly unstable during weight-bearing activities, even on flat ground.
That feeling of untrustworthiness.
Precisely. It can be the result of a single, severe, inadequately rehabilitated sprain, or the cumulative effect of multiple recurrent sprains that progressively stretch and weaken the ligaments. This chronic instability often leads to debilitating chronic pain, significant difficulty with activities like walking, running, or playing sports, and in the very long term, dramatically increases the risk of developing early-onset osteoarthritis and further damage to the underlying articular cartilage and bone within the joint due to abnormal loading patterns.
Leading to arthritis down the line.
A very real risk. When we look at long-term symptom statistics, the data is quite sobering. Research indicates that between 5% and 46% of patients report lingering pain years after their initial injury, and a staggering 33% to 55% continue to experience a sensation of instability or giving way.
Wow, over half in some studies.
Yes. While acute pain typically decreases rapidly within the first 2 weeks post-injury, a notable percentage between 5% and 33% still report some level of pain, even at 1-year follow-up. This powerfully highlights that simply getting over the acute pain is by no means indicative of a full recovery or resolution of the underlying issue. A significant and often overlooked cause of persistent chronic pain following an ankle sprain is actually a missed initial injury. These are often subtle but clinically significant pathologies that weren't picked up in the acute phase.
Things missed at the time.
Exactly. This can include missed fractures, such as those to the base of the fifth metatarsal, the anterior process of the calcaneus, or more subtle fractures of the lateral or posterior process of the talus. Osteochondral lesions, which are areas of damage to the articular cartilage and the underlying bone, most commonly affecting the talus. These can cause persistent pain, catching or locking sensations. Injuries to the peroneal tendons, which are key dynamic stabilizers. These can involve tenosynovitis, subluxation, or even full ruptures. An undiagnosed or inadequately treated syndesmosis injury, high ankle sprain, which, as we discussed, is far more severe and takes much longer to heal. Tarsal coalition, which is an abnormal fibrous, cartilaginous, or bony connection between two or more bones in the hindfoot. It can predispose to sprains and become symptomatic after trauma. Various impingement syndromes, such as anterior or anterolateral synovitis, inflammation of the joint lining in the front of the ankle, or impingement of the anterior or inferior tibiofibular ligaments from scar tissue. Underlying hindfoot varus malalignment, which places chronic stress on the lateral ankle structures.
Or even stretch neuropraxia, where a peripheral nerve, often the superficial peroneal nerve, has been stretched or compressed during the sprain, leading to neuropathic pain or altered sensation in its distribution.
Quite a list of potential missed problems.
It requires a high index of suspicion. A truly thorough clinical evaluation is thus paramount to prevent these crucial oversights. The overall prognosis for ankle sprains is generally positive with proper treatment and dedicated rehabilitation. However, the ultimate success of recovery is highly dependent on the initial sprain grade, the presence or absence of any other associated injuries, both diagnosed and those that might have been initially missed, and critically, the patient's unwavering commitment to their rehabilitation program.
Patient compliance is vital.
Absolutely vital. Incomplete rehabilitation is, without doubt, the most common single cause of chronic ankle instability and subsequent re-injury. Patients who discontinue their strengthening and balance exercises prematurely will inevitably find their injured ligaments and the surrounding dynamic stabilizers weaken, putting them at exceedingly high risk for future sprains. It's also crucial to counsel patients that while surgical interventions are sometimes absolutely necessary for chronic instability or other associated complications, they do carry their own inherent risks. These can include the general risk of surgery like infection or nerve damage, a potentially prolonged recovery period with strict immobilization, and the unfortunate possibility of some residual loss of ankle range of motion postoperatively, even with the best surgical techniques.
Surgery isn't without its own issues.
Never. So the decision for surgery is always a careful, considered one, weighing these risks and potential benefits against the patient's individual circumstances and goals. Our aim is always to guide the patient to the best long-term outcome, whether that's with or without a scalpel.
That truly underscores the profound, often long-term impact of seemingly simple injuries and highlights the absolute imperative for comprehensive, diligent, and patient-centered care. Prof. Moimam, you've guided us through an incredibly detailed and remarkably insightful deep dive into ankle sprains. From the foundational anatomical understanding and nuanced classification through to the comprehensive treatment strategies and, crucially, those vital prevention methods, you've provided an invaluable, actionable overview for all of us as mid-senior medical professionals. What really stands out from our conversation today is the absolute importance of a thorough clinical approach right from the outset, meticulously ruling out those missed injuries, coupled with an unwavering commitment to comprehensive and often prolonged rehabilitation. These elements are unequivocally key to mitigating those potential long-term complications we've discussed, ensuring our patients don't get caught in that frustrating cycle of chronic pain and instability. We genuinely hope this deep dive has offered you some new perspectives, perhaps it clarified some complex areas, or reinforced critical best practices in your own clinical encounters. If you found this deep dive valuable, please consider rating and sharing it with your colleagues. It truly helps us reach more professionals like you.
My pleasure entirely. To leave you with a final thought, while ankle sprains are indeed ubiquitous and almost daily occurrence in our clinics, our continually evolving understanding of ankle biomechanics, the sophisticated rehabilitation principles we now have at our disposal, and the advanced surgical techniques available offer us genuinely significant opportunities. The true challenge for us as orthopedic professionals lies not just in knowing these advancements, but in the consistent, meticulous, and diligent application of these principles in every single clinical encounter. Because ultimately, this isn't just about treating an injury, it's about fundamentally preventing debilitating long-term consequences and, more broadly, significantly enhancing our patients' overall quality of life.